just for those who are new to these sessions, I'm Nandini Sadasivam. I'm one of the haematology consultants at Manchester Royal, and I'm also the network lead for the North of England for Thalassaemia and Rare Anemia, HCC. We do run these educational sessions quite regularly now, and I'm absolutely delighted to introduce to all of you Dr. Laxmi Balmuri. He is endocrinologist and a bone and diabetes consultant at Manchester Royal since 2018. He completed his training in the Northwest Deanery, and he has been doing the joint endocrine and bone clinic for thalassemia and rare anemia patients with me for the last 18 months. We run every 6 weeks a clinic and an MDT, and it's been a real success, and we've had very good feedback. He's also been part of the UK Thalassaemia Standards writing group, and he's written some of the chapters that for the UK standards. And he also is an honorary consultant with the university supporting undergraduate teaching at MRI. He does educational and clinical supervision for trainees in diabetes and endocrinology, CMT, clinical fellows, and foundation trainees. And he supports the clinical governance in the department and the trust for quality improvement and mortality review. So, Laxmi, over to you. Thank you so much for doing this session. If everyone could mute your end, and we can put questions in the chat or ask some questions after the teaching. Thank you.
Thank you, Nandini. Thank you very much for your kind introduction. And I've been fortunate to work with the team here with the hematology and other disciplines which help with the thalassemia management. It's really fortunate, and also fortunate to work with the Thalassaemia UK working group as well. So sorry for the delayed start. I'll just go straight into the presentation. So it's about my objectives for today. So we can discuss briefly about thalassemia distribution in England and also globally quickly, followed by a quick slide about what causes endocrine dysfunction in thalassemia. Then we can discuss it elaborately about endocrine complications and bone complications. Also, short stature, diagnosis and management, delayed puberty and pubertal induction. So I will try to be as precise possible so that it can be just easy to understand, and so for audiences to make a further decision regarding when to refer and whom to refer. And also briefly about hypogonadism and HRT, basic principles. And a popular topic, it's a vitamin D deficiency, because a lot of our patients do have vitamin D deficiency. Okay, coming to thalassemia distribution, as you can see, thalassemia is more common, prevalent in Indian subcontinent, Southeast Asia, and also Eastern Mediterranean region and China. Less common so in Europe and Americas. So if you look at the UK, so it's again, it's kind of one of the low prevalence area. But why it is unique, that why we have to focus on thalassemia management, it's because we do have a lot of patients, as UK is mainly England is cosmopolitan, and we attract people from across the globe. And so we can see the more prevalent in Midlands, West Midlands, and also followed by Northwest, East Midlands, and more focused in London as well. And it's less common in extremes north or south of England. So we do see a lot of patients with the thalassemia. Okay, so when coming to a quick slide about the distribution or characteristics of thalassemia patients, so that this probably would help us to see and what we expect from thalassemia patients regarding their age group and ethnicity. This slide, we can see that most of our patients are young, but we are seeing increasingly more common elderly group and even geriatric age group. So in one way, it's very good that a lot of our patients are living longer, but that also stresses the importance of for us to continue monitoring for their complications and manage throughout their life. So at the same time, a challenge. So as we mentioned, especially people come from Southeast Asian and things. So that's why you can see at the same time. So the people from the Pakistani origin, Indian and Bangladeshi, and a few of them are, if you can see extreme on the right side, there are some unknown Asian background as well. So that means data is not very clear. These are all actually, so I took this data from HCC's 2021 one, so it's not too old. So this is kind of reflect the patients what we see in the clinics. Most common diagnosis is a beta thalassaemia major, followed by intermediate and other combinations with other form of endocrinopathies, other kind of hemoglobinopathies. And most common form of treatment, what we see is a chelation with transfusion and a few people on hydroxyurea. Okay, so this is a quick slide. I know it's very busy, sorry for that. But it is to understand what happens in thalassemia to cause endocrine dysfunction. The left side of the slide indicate where iron is coming. Obviously, with anemia, increased intestinal absorption, and also with the blood transfusions, we're giving mostly the iron. So whatever is unsaturated, that is when transferrin is saturated, so the remain free non-transferrin bound iron or labile plasma iron, that's a free iron, plasma iron, will go to the different organs, particularly endocrine organs are sensitive, so go to there and then cause injury to the cells. So that's why the damage to various organs and also endocrine organs that will happen and causing endocrine dysfunction. So what are the endocrine complications we're talking about? So pituitary injury causing hypopituitarism, hypothyroidism, hypoparathyroidism, pancreatic injury causing diabetes, bone injury can cause osteoporosis, deformities, fractures, hypogonadism, either because of the involvement of the pituitary or from the gonads directly itself, or adrenal involvement, again, it's from the pituitary dysfunction or direct adrenal gland involvement itself. As per Sanctis et al., we know that by far more common complication is hypogonadism, and hypogonadism, short stature, delayed puberty. These are all like a complex problems together in early childhood and adolescent. And also we have complications related to dysglycemia, hypoparathyroidism, hypothyroidism, and adrenal involvement. These are very rare. Getting to the pituitary, hypopituitarism, mainly we're talking about pituitary hypopituitarism causing ACTH production will be low and leading to so it's hypogonadism. So it is LH, FSH, gonadotrophins. They're very sensitive. Gonadotrophs are very sensitive for hypoxia and also for the iron deposition. They are the one early and also most commonly involved organ. So that leads to LH-FSH. So a lot of our people have a combination of both secondary and primary hypogonadism that makes a situation sometimes can be tricky or complex. and primary or secondary hypothyroidism. So we can talk a bit more about in the next slide. Growth hormone, gonadotropes. While gonadotropes are more commonly affected, but other lactotropes and other cells also very sensitive for the injury from the iron, so that can lead to low growth hormone secretion, and also ACTH production also goes down. So hypothyroidism. So what are the causes of hypothyroidism? So we mentioned whether it could be from the hypopituitarism or direct thyroid damage from the iron deposition. How do we differentiate that? It's very important. It's coming to the investigations. So when we check thyroid function tests, we check mainly free T4, free T3, not necessarily all the time, so it's not important. But if it's case of secondary hypothyroidism or associated other thyroid problems with the thyrotoxicosis, because these people can have other autoimmune diseases. So then you may have free T3, but usually tested free T4, TSH, and if we are suspecting secondary, that is a central hypothyroidism, we should check other pituitary hormones as well, because they're commonly associated with other pituitary hormone deficiency. So a quick slide about this. So when we're talking about the primary hypothyroidism, so the problem is thyroid in the thyroid gland. So we expect low T4 or low T3. So that gives sense feedback mechanism to stimulate the TSH and TRH. So then if we check the blood test, if free T4, free T3 are low, TSH is high, that is a primary hypothyroidism. But if T4, T3 are low, but TSH is not high or not enough high, that means not necessarily it has to be a completely low. It is not raised appropriately as we expect. That also can signify it's a pituitary problem. So low free T4, low T3, inappropriately elevated TSH, or normal TSH, that is secondary hypothyroidism. It's difficult from our clinically to say tertiary, that means it's nothing, but usually the term given to the hypothalamus dysfunction, because you can also say TRH, but it's difficult to measure TRH in the clinical practice. So that will be the similar to the secondary hypothyroidism. So there is a term that we also come across commonly is subclinical hypothyroidism. So how do we differentiate? It is hypothyroidism. That means we expect low T4, low T3, but that is the primary hypothyroidism. But in case of subclinical hypothyroidism, the T4, T3 are normal, but TSH is raised. So the TSH is the early indicator of hypothyroidism. So that's where we differentiate. Subclinical hypothyroidism, T4, T3 normal, but TSH will be high. So we don't have to treat all people with the subclinical hypothyroidism, but if we can monitor them regularly and we can treat them, or if people are symptomatic with hypothyroidism, and then also we can treat and to improve their symptoms as well. So how we manage then? The treatment is levothyroxine replacement. So we have to treat either GPs are very good in managing the hypothyroidism. So we can start the low dose, for example, 50 micrograms to 75 micrograms, depending on their age group and then we can monitor thyroid function tests after 6 to 8 weeks. It takes that long for us to see whether how much improvement we made. So we try to correct TSH to around within the normal range, means less than 4, but around 2.5, particularly if patients are young and fertile and they are looking for the other fertility issues as well. So we try to keep TSH around 2 to 2.5. And I put the last line, the timing of medication. That's why it's important, because a lot of people with the thalassemia take medication, oral medications, for example, XJ. So we have to make sure that thyroxine taken first thing in the morning, half an hour before breakfast, to allow the maximum absorption. Otherwise, we may have to end up giving increasingly high doses of levothyroxine if it's not required. Next, adrenal insufficiency. As I said, it's rare, but how does it present? So it presents as it's a low cortisol condition, so tiredness, low blood pressure, and people are very tired in general. So what are the causes? Again, it is from the adrenal primary involvement, adrenal deposition of iron, or hypopituitarism itself. If it is from hypopituitarism, they may have other pituitary hormone dysfunction as well. So that means, how do we investigate this? So obviously we check cortisol. Why we check cortisol first thing in the morning? Because as the day progress, by afternoon to evening, the cortisol levels will go down. That means the cortisol steroids are more, they are more in the level when we are stressed. That means first thing in the morning. As we go up by midnight, they're completely absent. If we check any random cortisol in the afternoon and evening or night, if they are low, it could be normal for them. So, but we can reassure the patient by checking the cortisol in the morning. If that is low, and then we can go for short acting test. Why I put is the 200 is, I know it's a variety. There are different guidelines that you check. Usually, if it's more than 400, definitely normal. Sometimes 200, 300 also people worry. But if patient is symptomatic and they are tend to on the lower side, between 200 and 300, then we can check short acting test and also the basal ACTH. So why we check ACTH? That will tell us whether if the problem is from the adrenal gland or the pituitary. If it's adrenal hypoadrenalism, that means because of primary, then ACTH will be high. If it is a pituitary problem, ACTH will be low or not appropriately elevated. So how we treat? If short acting test is failed, then you need to speak to your endocrine colleagues to ask for appropriate advice, mainly replacing the glucocorticoids. Usually we give hydrocortisone, which is again depending on the day. Standard dose is like a dose in the morning, and then the doses like a 10 milligrams, 5 milligrams, 5 milligrams by evening, but not necessarily. Sometimes we may give even prednisolone as well. So it is patient specific and how much adrenal insufficient they are. Next, hypoparathyroidism. So this is kind of a late, one of the, not late, but happens in the second decade, not very early complication, but we check them every yearly after first decade onwards. And the literature shows it's a slightly male predominant, which is slightly less complicated, less common than other complications. So what happens? So why parathyroid is very important for us? Because parathyroid hormone is a very sensitive hormone to calcium in the plasma or serum. If serum calcium is low, that will give signal to the parathyroid glands to produce more parathyroid hormone to bring more calcium from the reserves, for example, like a bone, and it will increase the reabsorption from the kidneys, and also through vitamin D, it will increase the absorption from the gut. So if it is high, the calcium, PTH will be suppressed, thereby try to improve the calcium, reduce the calcium in the blood. I will try to share symptoms, of course, we commonly see are hypocalcemia, the symptoms of paresthesia, tetany, seizures. So why they have these? Because calcium is very important to maintain the action potential, to threshold the stimulus, to maintain the threshold for the stimulus. If it's hypocalcemia, they have a very low threshold for the stimulus. That means even minor stimulus can give rise to symptoms, giving to sensory, even motor symptoms as well, seizures, even cardiac. They can, so even minor stimulus can precipitate all these side effects. So what investigations we do? So this is a very busy slide, but it's very important. The slide that I most like in metabolism. We focus only on mainly the PTH in the middle. You can see that parathyroid hormones. We have 4 parathyroid hormones posteriorly to the thyroid. So this is very sensitive to the calcium in the blood. So if low calcium parathyroid will give rise to calcium sensitive receptors from the parathyroid gland, increase the parathyroid, that will increase the bone resorption, increase the calcium absorption, and it will activate vitamin D to activated vitamin D so that it will absorb more calcium. So all the investigations basically now we can understand are around this. So that means we check parathyroid, we check calcium, we check phosphate, we check vitamin D. So, and then why vitamin D? So vitamin D, low level of vitamin D can cause low absorption of the calcium from the gut. So that's why it's very important. And people with the kidney failure, and we may not have this activation going on. That's why we give activated vitamin D as well, in addition to normal vitamin D for the problem with the treatment. So urine calcium creatinine ratio, this is another test, very important to look for calcium excretion. People with the parathyroid hormone, low parathyroid hormone, they can easily excrete calcium because there is no parathyroid to stop resorption. So they can easily leak the calcium. So when we treat hypocalcemia, when we give calcium, we have to make sure the calcium has to be in the lower normal range. For example, in our hospital, the numbers are like a 2.3 to 2.6. I will keep them in between 2.2 to 2.4. Why I don't increase more than that? Because extra calcium will be leaked into the kidneys, causing nephrocalcinosis. So we can only give the calcium enough to improve their symptoms. We don't have to keep them in the normal range. So that's why we check the calcium creatinine ratio. So this is a very quick spot test. You can check in the lab. That will give us an idea. It is too much calcium, but the gold standard is 24-hour urinary calcium. That can give us the total calcium excretion if we are suspecting somebody having a renal failure and associated with the kidney stones. So we manage with the calcium, replacing with the vitamin D. As I said, activated vitamin D for people with the kidney failure and hypoparathyroidism, because parathyroid in the absence of parathyroid, vitamin D can't be connected to the activated vitamin D. So we have to give calcitriol or alpha calcidol. These are the activated vitamin D as well. So it's very important to give that. So growth and puberty. So this slide gives us a brief overview of how, what, and when, what factors manage the growth or kind of influence the growth. So 30% of our adult height is grown in the uterus. Then infantile, it's 15%, and the puberty, you can see that small amount. So infant and puberty. So throughout the childhood, they grow mostly is 40% of height. That means factors influencing this time, these periods will obviously influence their adult to the final height. So that's why I think very important when people with thalassemia, when they're diagnosed with thalassemia, and then starting the treatment as soon as we can prevent the short stature, or we can improve the growth for them as soon as we can. And also at the puberty, and again, it's important because the hormones here at this time, if LH, FSH and testosterone or estrogen, so their pubertal spurt is very important. If they don't have that spurt from the pituitary or primary hypogonadism, they can lose this height as well. So various factors in different stages of our life are very important for somebody's growth. So a quick slide about the puberty. If we can look at that in the male one, so the hormones fluctuate very rapidly during the childhood and when the first 9 months. Once they are like when we started seeing the patients with thalassemia at that time, so you can see that gradually that testosterone levels not that much, but at the time of the puberty, it's very important that testosterone is very important at the puberty going to the adult level. So at this time, if somebody is not having enough testosterone, so we have to give testosterone to stimulate the puberty. So in the next couple of slides, we can discuss briefly about how to do that. Induction, puberty induction. Similarly, this is the females. Again, see puberty at the puberty time. So estrogen levels will go up at the time of the puberty. So to achieve the puberty, you need to have enough hormones as well. So we'll look at that estrogen and see progesterone there. But so estrogen is very important. That's why to give the puberty induction, so we give estrogen replacement during up to 50, up to the premenopausal age. So these are very high, and after that they go down. So depending, because we already discussed, we can be a bit fast here. So growth, different phases of the growth in different times. So different factors involved. We need to make sure that we investigate at that particular phase what could be there. We can, so in the phase 2, we can check about the other axis, other hormones as well, other than the growth hormone. And in the puberty, we check obviously the testosterone, estrogen, LH, FSH. The causes again, we already discussed. So how do we find out? Of course, it's mainly done by the pediatric groups, my colleagues there. So I'm just running through the slides so that if anything there, because most of you involved with the pediatricians, or you see the patients, the kids as well. We check height and weight, bone age, estrogen, testosterone, LH, FSH, growth hormone, and also thyroid hormones, because they're all influence that. How do we treat that? Appropriate chelation, appropriate hormone replacements, nutrition, supporting the nutrition, and also emotional factors. So puberty. So what is? So there are a couple of slides there after this one, after this as well. So we discussed that briefly about why people, why thalassemia or any other people with the dysfunction of the hypothalamo-pituitary adrenal axis or over gonadal dysfunction itself can cause delayed puberty. So what are the tests we do? Again, it is sometimes inseparable, that puberty and the growth, so that's why it's usually combined. So we check for both of them. So we check height and weight, estrogen, testosterone, LH, FSH, thyroid hormone. And so how do we monitor somebody's puberty? By the Tanner staging. This is one of the well-known things. So in both boys and girls, so we can check somebody's puberty and monitor that puberty if they are on any puberty inductions. So we can gradually see how much they are improving with the induction regimes. And we need to, again, how do we treat it? Treating with appropriate hormones. So we can discuss that in the next slide. So what is delayed puberty? If somebody, the boys, if there is no testicular development by age 14, in the girls, it's no breast development by 13, or if they have developed breast but no periods by 15. So this is from our NHS diagnosis. I think it's worldwide, it is almost similar. So what is primary amenorrhea? If somebody is not having a periods by 15. So how do we treat them? Of course, you refer to endocrinologists or pediatricians, usually pick up by the time they come to adolescence. But if they're coming a delayed puberty or puberty arrest, that means if they come towards adolescents or adults, but still the puberty is delayed is puberty. So we can help them with giving the estrogen. So we treat a delayed puberty with the estrogen. So that is the hormone if somebody to do that from the girls, and with the testosterone in the boys. So just a couple of slides, next couple of slides for the induction regimes. So we don't give combined oral contraceptive pill for a puberty induction because we need estrogen. In the combined oral contraception pill, we have progesterone as well. So you need estrogen priming first for a couple of years at least before you give progesterone for somebody as a part of the puberty. So we don't just give the progesterone and combined oral contraceptives because the synthetic estrogen in the combined progesterone is different than the simple estrogen as a form of hormone replacement therapy. So this high synthetic estrogen can cause associated with other problems, hypertension, thrombosis, dyslipidemia. That's why we have to give estrogen-based regimes for that. Progestations only we start once we reassured enough that the uterus is developed. That means we give unopposed estrogen for a couple of years, then we give progesterone to get them to have a breakthrough bleed, a periods. And we can also sometimes check endometrial thickness by the ultrasound to see whether they're ready for the progesterone treatment challenge for the withdrawal bleed. So once they completed puberty, or achieved the puberty, and then period started, then we can, somebody with the still hypogonad, people with hypogonad, then we can give adult hormone replacement therapy after that. That means estrogen, progesterone, and depending on their uterus status. So until then, we give estrogen first, and then progesterone after 2 years. If they come too late, that means they're coming up to 19, 20 years or so, we can pace up the estrogen with slightly higher doses and then progesterone, so we don't have to wait for this 2 years. So this is a busy slide. I put it for this. What we can do is for testosterone for the boys. So it's mainly testosterone given small doses, 50 milligrams for 1 year, 6 months to 12 months intramuscularly. And then dose will go up to 100, 150. So it will be again like every 2 years or so to somebody to get into to achieve puberty, and we can use the Tanner stage again while we do that. So there are different forms of the testosterone, but usually, and again, I can refer to usually pediatricians deal with that, or if they come to us, if we think that still they are not achieving the puberty, we can give that as well. The girls, so I don't want to be too specific. So what we give is that, so there are, as I mentioned, puberty induction, we give with estrogen. So estrogen can be given by patch or tablets. Most preferred or less side effects is the patches, but we can also give them the tablets, 17 beta estradiol or ethinyl estradiol tablets as well. So how we give, gradually we have to increase the doses so that endometrial thickness build up, endometrium build up over the period of 18 months to 2 years, so that we can give progesterone later on. So this is the summary of all the, this is the Royal College of gynecology slides taken from. So either patches or tablets can gradually go up the doses. And then after the 2 years, then we'll start adult treatment, that means adult contraceptive pills. Either at the time you can use it or HRT, depending on it is individual choice. We discuss individually with the patients. So then hypogonadism. So again, it can be a hypogonadotropic hypogonadism, that is involvement of the pituitary or hypothalamus problems, or if it is hypergonadotropic hypogonadism, that is a problem with the ovaries or testis itself. So how we diagnose: estrogen, progesterone levels, testosterone, if they are low, and also LH-FSH low at the same time, that means problem with the pituitary or hypothalamus. But if LH-FSH are raised, that means it is the primary problem with the male testicular problem or ovaries. Usually the prognosis, it is a favorable outcomes from the fertility point of view. It is a bit good with the hypothalamic origin or hypogonadotropic hypogonadism, because the entire axis is intact, so that we can give LH-FSH treatments so that the testis and ovaries can be stimulated. But if the problem is with the ovaries or testis, there already a damage happened to them, and there is ovarian reserve or testicular reserve probably very less or not much there. So even though if you give LH-FSH, you may not have good effect, because actually the indoor organs are affected. So again, we've checked that. So how we treat them, hypogonadism. So if it's very important why we have to treat people with the hormones, because estrogen in female and male, testosterone in the males, they're very important, not only for the physical growth, it's also emotional, neurological growth, and also sex organs development as well, and also fertility. So if somebody don't have the hormones, we need to replace them. Otherwise, they will have all the features of estrogen deficiency or testosterone deficiency, and they can have low libido, or bone density will go low, the future cardiovascular problems. So quick slide about how we decide or what is the best way to put somebody on HRT. If somebody has a uterus, that means most of our patients with most of our people with young adolescent and things, so usually have a uterus intact. So to replace the hormones, we have to replace both estrogen and progesterone. If somebody has hysterectomy, or somebody has got already Mirena into, that means progesterone is already going, then estrogen, we can give only estrogen. So what happens if we only give estrogen in uterus intact people? So what happens is estrogen will build up the uterine endometrium continuously, and then it can lead to endometrial cancer if unopposed. So that means we have to give progesterone to shed that, or give periods, so that endometrium can be remain healthy. So that's why, so if somebody has uterus, if we have to give both estrogen and progesterone. So we can give that, as we just discussed, we can give in different forms. So if somebody has got, so most of our patients are young, so that means they need to have periods. So we gave both estrogen and progesterone either in the patches or tablets. So estrogen will be continuously given so that it will have effect, and the progesterone will give intermittently to cause periods, either monthly periods or 3 to 4 monthly periods, depending on patient choice. So we can give that either with the only patches, or patches in combination with the progesterone tablets, or progesterone in the IUD or Mirena coil as well. So it is all depending on what could be the best choice for the patient. If somebody is a postmenopausal, so we can mimic that to normal. That means we don't expect the period. That means we can give continuous estrogen, continuous progesterone. That means they don't have a period. So whenever we give estrogen and continuously will give progesterone intermittently, they will have periods. That's the fundamental principle. So we can give both all estrogens and progesterones. We can give either gel, patch, or spray. And we can use various combinations as well. So how do we monitor the transdermal therapy? For example, we're giving this HRT. So we'll give them estrogen. Most of our people are young, and so they need slightly higher doses. So what we start with the low doses of estrogen, and gradually we can increase the patch or tablet doses. And then we're talking about, I don't want to give the names of individual things, but estrogen patches like usually 50 to 75 or 100 patches. So most of them will be, I tend to give them up to, if possible, we tolerate 75 to 100, because that is probably an adequate dose for them, for the bones and endometrium. Progesterones, depending on what they tolerate, because a lot of the side effects are from the progesterone, from their side effects. So we may have to change the progesterone component things, and more biological ones now we coming like eutregesterone and things. They give least side effects. So we can use them as a tablet, or we can give as the progesterone patch as well. So we already discussed the tablet, patches, implants. So as I gave you that, the tablets, there are variety of different tablets with the names. I prefer to try to use the patches, but also use people with the tablets as well. And progesterones, micronized progesterone. So variety of the HRT combinations that we can use from the market. So this is the one slide I like, that what is the equivalent doses for the tablets to the patches. I think it's almost coming to a couple of more slides. Diabetes side. So we see few people, not very common, but we do have a lot of people with the diabetes. That's because her genetic predisposition itself, or pancreatic iron deposition. So how do you investigate then? The gold standard is a oral glucose tolerance test. So how we diagnose that? With, if it is a fasting glucose, if it is more than 7.8, or 2-hour glucose more than 11.1, that is diabetes. If it is impaired glucose tolerance less than 7.8 to 11 is 2-hour glucose. Mean. So we can see that hemoglobin. If it is a glycated hemoglobin, that's what we see, the hemoglobin A1C. But if it is what we try to measure is albumin and glycated proteins. This is what we measure as the fructosamine, because you know well more than me that we can't take hemoglobin A1C as a predictor of the diabetes diagnosis and management and monitoring, because hemoglobinopathies won't give accurate result. So what we check is the fructosamine. Every 2 to 3 months, we check here for monitoring, not for the diagnosis. And next, so other way that we can diagnose somebody's the diabetes is checking their glucose levels, capillary glucose levels. If we can provide a glucometer so they can check glucose levels if they're continuously high and if they're symptomatic. That's also on the way of somebody's diagnosing a diabetes. We rarely check C-peptide, but we do check them. People with to see the pancreatic reserve. It will give C-peptide levels. If they are low, that means there's not much pancreatic reserve, and they may need of insulin requirement as well. Some of what people can have associated type 1 diabetes, autoimmune conditions. If they have other autoimmune conditions, then we need to suspect. In that case, so we may have to diagnose them with antibodies, selecting specific antibodies that will give you if they are positive. So they may have a type 1 diabetes as well. So it's rare, but it can happen. Ketones we don't check often, but if somebody's significant pancreatic insufficiency and they require insulin, then ketones will go up. So if the ketones going up, that means it's insulinopenia. There's not much insulin there in their body. So we may have to replace them with insulin as temporarily or long-term treatment. Hemoglobin A1C is not useful. How do we treat? Treat with any other diabetic patients, dietary management, physical activity, metformin, and other oral diabetes, other anti-diabetic medications, and insulin. So bone disease, I'll try to simplify this because it's a very busy slide. So what we are trying to see is whenever there is a equilibrium disrupts between bone formation and bone resorption, that's where the bone disease comes. So, and also in thalassemia specifically, the bone marrow expansion, as you know, is very well. So that also can cause problem with the bone structure itself. That means quality of the bone is lost. So that's why they can have reduced bone density and easy fractures. And also, hypothalamus and pituitary and parathyroid, other hormone dysfunction can also indirectly affect the bone density. Renal involvement directly because of thalassemia or medication associated itself. Rarely exchange-related renal tubular acidosis or tubular defects can cause osteodystrophy, as well, osteodystrophy. Rare, but that also needs to be looking into. But most commonly, this is caused by bone marrow expansion and also hypogonadism, associated hypogonadism. That's why it's important that we treat people with testosterone and adequate estrogen. So what it does, it causes low bone density, because fractures, skeletal deformities, scoliosis, kyphosis. So how do we investigate? Obviously, we check for the thalassemia parameters, but also we check specifically to make sure that no other factors are involved. So we check bone profile, parathyroid, vitamin D, bone turnover markers initially, and DEXA scan. It's your case. And a quickie about the DEXA scan. Nandini, do we have?
Yeah, you can carry on, Laxmi.
I've got 2 slides after this.
Yeah, that's fine.
Okay, so DEXA scan, we check that if people with osteopenia or osteoporosis, when we are treating with either HRT or bisphosphonates, we monitor every 2 years or depending on it, 2 to 5 years. So it's not necessarily it's a fixed time, but we check them to see whether the treatment is improving or at least keeping the bone density stable. So what is osteopenia? Osteopenia is if T-score is -1 to -2.5. Osteoporosis is if T-score is more than -2.5. Actually, this is the sorry, it's typo, and G-score is more than -2. So in young people, most of us thalassemia people are young, so we use a Z score, not the T-score. because Z score is something that let's compare with the similar age group, the people with that gives most value for us to interpret. And the T score is the one we check for the postmenopausal women. That is for elderly people, which we compare with the younger cohort. So we check most of the people with the Z score, and if it is a more than -2, that is osteoporosis. We check VFA, that is the vertebral fracture assessment. When we check the DEXA, we can also ask technicians to check this, because that is a form of X-ray that they can do at the same time, can look at the vertebral fractures at the same time. This is the bone mineral BMAD, that is nothing but measuring bone marrow. Most of the young people can show, sometimes the DEXA scan can show relatively very low bone density, but we can calculate this BMAD to see age appropriate bone density. So a lot of times when we correct the bone density, it is kind of near normal. So that's why we can check bone mineral apparent density to give more accurate bone density. PQ-CT scan for peripheral qualitative, it's a qualitative function to check quality of the bone. We treat with the calcium, appropriate calcium, vitamin D replacement, bisphosphonates for the eligible patients, HRT, and some of them new treatment for somebody who is bisphosphonates are either not helpful or the osteoporosis worsening despite those. Remdesivir is just newly come up, but we don't have enough data that to giving them, but probably in the future that may come up. Just to give the slides, this is for everybody, if in case somebody wants to. This is from the NICE guidelines only. It's a vitamin D, how do we normally diagnose and replace the vitamin D. So if somebody is vitamin D deficient, that means less than 25, we usually give 20,000 units, a loading dose for a week or 10 days, followed by 20,000 units weekly. If somebody is insufficient, we can give weekly treatment, 20,000 units or 40,000 units weekly. If they are completely replaced, no need to treatment, they can use prophylaxis for the 1,800 to 1,000 units. Okay, thank you. I think this is done.
Laxmi, thank you so much, Laxmi, for such a comprehensive overview about endocrinopathy and bone disease. There's a lot to cover, and you've given a very good and excellent overview about this. So thank you so much. I'm going to ask audience for question and answer. If anyone's got questions, Eva, I'll let you take charge of some of these.
Of course. So, Barbara, your hands are up. Would you like to ask a question?
My question is about the thalassaemic patients. Do they have psychological support? Do they have access to good psychological support in your clinics at all? Because there's you're going through all of the problems, the chronic problems that they go through, and it's a lot as a sort of a clinical nurse specialist to sort of think about them and what they would be going through if they've got these sort of disease complications. And I just wondered, do they have regular access if they need it, to a psychologist? That's my question.
Thank you, Barbara. I'll answer that. Yes, so we do have psychology as part of the service. I also find that as a clinician who actually looks after quite a lot of thalassemia patients over the years, we do support them during the clinic with some of these queries, but they do have dedicated psychologists for sickle and thalassemia that they can access.
Thank you, Nandini. Are there any other questions at all?
So one of the things, Laxmi, I was going to ask you is you always, and I think it's quite a useful tip to share about thyroxine and chelation. Do you want to just elaborate a little bit about that?
Yeah. So levothyroxine absorption is very sensitive hormone, and it just if any other medicines we give along with it can reduce its absorption significantly. So we do see patients with the very high doses. Sometimes we did achieve to reduce the doses just simply by changing the time of taking the thyroxine, because its absorption has been affected by the other medication. So I would like to keep them if possible, to take first thing in the morning. Sometimes, rarely I say the night time, depending on when they are taking other medications. I would like to give at least half an hour to 1 hour gap before and after they've taken the levothyroxine, so for the good absorption. Otherwise, it may not absorb and we may have to increase the doses.
Yeah. Okay. And I've just got another question to ask about looking up for puberty. So I've had in the past where young people come across transition to adults, not having had very much in the way of, I think it's the awareness about doing these checks about puberty checks. If they don't go through the natural puberty and it's sort of missed, it can be picked up in adult. I think that's a question. Yeah.
Mm-hmm. Yeah, that's so the puberty, as you said, in the growth, it's kind of intertwined. So if a lot of people, we can see that they're very short and they're hypogonadal as well, either clinically or biochemically. So if we pick up them, and the height wise, I think it's sometimes we can do a bone age and see whether they achieved their final height or not. So, and if so, we can, so by knowing what exactly where they are in the puberty progression wise, so if we can give treatment, the hormone replacement, depending on that. So that means if they have hypogonadal and they have not developed secondary sexual characteristics, so we can give kind of late inductions to improve their body physical secondary sexual characteristics, and also to support the bone. So we can give, but we can give it fast, like we don't have to wait for 2 years to give that.
Yeah.
And we can check a basic ultrasound uterus and see what is the development like, and also we can check their ovarian function, but we can do slightly differently to cater the individual patients.
Yeah.
So we can do that, but most of them, unfortunately, they might have already achieved their final height wise, so we may not be much hopeful, but we can do from the secondary sexual characteristics point.
Yeah. So I think this is a lot more to be aware if you have patients coming from abroad, where the monitoring for puberty may not be as robust. I'd hope that with time, this will all be picked up in pediatrics before they transition to adults. Brilliant. Any other questions?
No other questions in the comments box. Oh, wait, I speak too soon. We have a question. What is your recommended vitamin D level for adults in this patient group? Some recommend a higher level of normal. Some are happy for a level just above 50. Thank you.
Yeah, it's a very good question. So, I mean, previously, there is a conflicting data in a few years ago that asking for higher than the recommended dose, but latest data it not show any more benefit of keeping them more than 75 or 100. So we do keep it more than 50, we're happy with, but as long as they keep that range within that, so I will be happy. So I don't keep them in the higher doses than that. So, but yeah, previously there were reports asking us to give more than higher doses, but more than 50 I will be happy.
Thank you very much. I muted myself there by accident, so apologies. There are no further questions in the chat, so I'd just like to say a very big thank you for coming here, Laxmi, and providing this really thorough education session. I've had a lot of people email asking for the recording, so once the recording has been edited, it will be shared to this group and via our website. So we do have all of our educational videos available there. So thank you again, and we would really appreciate some feedback.
You muted again.
Muted again. I do apologise. So there is a survey in the chat box. So if you could just fill it in, and that would provide us with some excellent feedback for Laxmi as well for himself. And just a very big thank you all for your attendance this afternoon.